You're watching CTOM TV. Knowledge is power. You've prepared some information for us about female reproductive cancers. So how would you like to begin?
Well, I think we should just go over the basics of it, what it is, what are some of the features, why that's relevant, and then we'll talk about a couple of our favorite treatment options and advanced treatment options that are currently available.
Okay.
So to start out with, female reproductive cancers are referred to as gynecological cancers.
Okay.
There's 5 main types: as cervical, ovarian, fallopian tube, vagina, and vulva. And each one of those has a variety of different subcategories.
Okay.
We've previously looked at ovarian, so we won't cover that today. And I think we'll just focus on cervical and vagina and vulva.
Sure.
Cancers.
Nadine, maybe on that note, you could post the link to the playlist on Alex's YouTube channel for ovarian cancers into the chat today, so people can find that easily.
Yes.
And you said those so quickly. I know it's like it's Greek to me. So could we slow down? We have ovarian, we have fallopian. That's as far as I got. What else? What else?
So we have vaginal.
Okay.
We have vulva.
Okay.
Then we have cervical.
Okay.
Then we have fallopian and uterine and ovarian.
Okay, so 6 different types.
Yeah.
Okay, thank you.
They're all collectively referred to as gynecological.
Okay.
So cervical, we'll go over cervical today. Cervical, 90% of cervical cancers are squamous cell carcinomas.
Okay.
10% are adenocarcinomas and other subtypes. So the vast majority is 90%. Now, I would say additional 90, maybe 95% of all cases of cervical cancer are HPV related, human papillomaviruses.
Can you say that again? What was that statistic?
90 to 95% are HPV related.
Of cervical cancers?
Of cervical cancers, yes.
Okay.
Yeah, vastly.
A
HPV.
huge amount.
So, obviously we could do a lot by eradicating the HPV.
Right.
The carcinogenic HPV strains. So microbiome also plays a big role in this too, in cervicovaginal cancers.
Okay.
There's a type of bacteria called Mycoplasma bacteria, and it's a parasitic bacteria that causes pneumonia and pelvic disease and inflammatory pelvic disease and urinary tract infections. And it also promotes the growth of HPV-related lesions. So there's definitely a microbiome component that influences the ability of HPV to cause cancer.
And we can do a lot about that as individuals.
Yes, we can
influence that.
We can, and in fact, a lot of women do influence urinary tract infections and yeast infections and so on by diet. Cranberry juice is a common one. Avoiding sugars. I think a lot of the common sense dietary practices most women are fairly aware of, from what I understand. And typically, these traditional practices have been associated with altering the microbiota and ensuring that you have a positive microbiota. So women with ovarian cancer, for example, and or BRCA1 mutations, but women who have BRCA1 and 2 mutations who haven't yet gotten cancer, are likely to have a unique microbiota. So the genetic changes that cause this cancer, as well as having this cancer, really do create or are associated with a unique microbiota. Not just this mycoplasma, but there's also, they're characterized by a lower community type O versus community type L. And so these are lactobacilli. So a high proportion of the lactobacilli species is associated with a protective low vaginal pH. So having a low pH is fairly important for women. Low vaginal and cervical pH is fairly important because it really does impact the types of lactobacilli that you have, whether they're protective or non-protective, and promote things like HPV growth and so on.
Mm-hmm.
So with that in mind, it brings up the question of whether cervical and vaginal cancers are an immune hot cancer. I would say that they probably are. We don't have a lot of data on this yet, but what this means is that there's an interaction with the immune system based on probably the microbiota too, that can be indicative of a benefit of immune-based approaches.
That's what immune hot means?
Yeah, yeah. So we're, the big quest in cancer is finding immune hot tumors.
Because immunotherapy is so
beneficial,
powerful.
such a
Yeah,
beneficial
we've seen
tool.
that time and again.
So interestingly enough, some of the molecular features of cervical cancer, some scientists use a simple test called FISH, fluorescent it's basically a process that, FISH is fluorescent in situ hybridization, if I recall correctly.
That sounds about right.
We haven't used it a long, long time. It's commonly used in pathology to look at differences in chromosomes and whether they've been changed and altered in parts of chromosomes. So a bunch of scientists use this FISH technique for the genes encoding PDL1 and PDL2, and also the centromere region of chromosome 9. And what they found is that in cervical cancers, 67% of the patients with cervical cancers had this co-gain and co-amplification of PDL1 and PDL2. And this is important because this indicates that if you have high PDL1 and PDL2, that means that you have a really good chance of responding to PD-1 inhibitors. Not in every cancer, but specifically in this type of cancer. So the cervical cancers, 67% had this co-amplification of these two important immunotherapy markers. That's a lot.
PDL1 and 2.
Yeah, PDL1 and 2. Yeah, 67%.
67%.
Yeah, of cervical. 43% of vulva cancers had that. And then another 19% had what we call polysomy, which means multiple chromosomes. 90% of cervical. Was it 26% of vulva had polysomy? So that's also an indication that immunotherapy would work with these patients. So PDL1 expression was later found to be highest in cases of co-amplification and the lowest in disomy. So a small percentage of patients in both of cervical and vulva had disomy. So what this is saying is that if you have cervical or vulva cancer, you can get the simple FISH test for this. You could probably pay out of pocket. We could help you access this test. You can also get tumor DNA sequencing, which is obviously recommended. But if you can't afford the tumor DNA sequencing, this FISH test is a quick, simple test that is easily done in most pathology labs. And it will tell you whether you have a good chance of responding to these, to immunotherapy.
Well, that's good news.
Yeah, it's great news. So once again, we're seeing that cervical and vulva, vagina cancers are potentially an immune hot tumor, and that there is some interaction with the immune system. So what is the reason for that? Is there some sort of logic behind that? Well, if you look at HPV, HPV infects the parabasal cells, and those are the undifferentiated stem cells that are in the epidermis. And so they're found in the transformation zone of the cervix. And this area gets more accessible, so it's typically covered up. But these stem cells that are undifferentiated and can potentially be turned into cancer-causing stem cells, like any other stem cells, are exposed during puberty, pregnancy, when using oral contraceptives too. So these are risk factors in that if you have an active HPV infection, then all of a sudden, typically the HPV virus cannot affect these cells because it doesn't have access to them. They're buried deep below, layers of skin of the epithelial cells. So during these situations like puberty, pregnancy, and oral contraceptive use, these cells become more accessible, and the HPV infection, if you have it at the time, can now go on and affect these stem cells and cause a cancer. So also microabrasions on the surface allow better access to this basal cell layer, which is below several layers of epithelial cells. So that would be indicative of, an environment where the HPV can access these cells, and it's a prime opportunity for it to cause these cells to become cancerous.
Right now you're referring to the cause of
the cause of HPV related cervical cancer.
Okay.
Yes, and because of this, because it's the HPV causing this, it's a little easier for the immune system to be involved. And also, when we see this co-amplification of PD-1 and PD-L2, that just creates this perfect storm for immunotherapy. So I would like to talk about some of the immunotherapy approaches right now that have been really beneficial, that are relatively new. So one of them is, I just saw recently, that a process called adoptive cell transfer using tumor-infiltrating lymphocytes is somewhat beneficial in this approach. So this is an approach that's been around for a long time. One of my favorite scientists of all time, Dr. Steven Rosenberg, really spent a lot of time on this with melanoma. Basically what it means is you go inside of a tumor and you find there's two types of T cells you're typically going to see. You're going to see these T regulatory cells, and you're going to see these T infiltrating lymphocytes. So the T regulatory cells are usually what they call CD4 positive, and the TILs, the tumor infiltrating lymphocytes, are usually CD8 positive. So the CD8 positive TILs are the ones that we're most interested in, because when they're activated, they go inside of the tumor and they destroy it. Now, what happens is once they enter a tumor, the tumor has all of these different processes, such as PD-1 and so on, that it will use to inactivate this tumor. Or inactivate these TILs. So the TILs will enter into the tumor and then they'll get turned off. And they'll remain there in this turned off state until they have the release of the brakes. And that could be PD-1, could be EDO, could be one of 10 different ways or 11 different ways that the immune system uses to inactivate these cells. There's many of them. Typically PD-1 is the one we look at, but there's a variety of them. So what scientists do is they will take that tumor, they will isolate those TILs because we know that they are attacking the cancer, and then they will grow them outside of the cell in petri dishes, boost them up, make them really healthy. They'll freeze them, and then they'll ship them back. And then what will happen is the patient will get this lymphodepletion chemotherapy, typically with a cyclophosphamide or fludarabine combinations. They'll get that for about 7 days, and it will kill off their immune system. And then they'll inject these boosted TILs that were isolated from the tumor back into the body. And they'll also include something called interleukin 2. They'll do 4 to 6 doses of this interleukin 2 to boost these cells within the body. So the whole process is designed to basically use your own immune cells, isolate and use immune cells that have been shown to enter your tumors, but have been turned off, is to boost those and then to, re-inject them back into your body. So this is referred to as adoptive cell transfer. They've been doing this for a long time. There's some benefits in melanoma cells, but they haven't really gotten anywhere with it because A variety of different reasons.
Okay.
You know, one of the issues is that well, I'll get into the issues in a minute.
Yeah, why are we talking about it then?
Because in this particular process, there was a recent study. The process or the drug they used was called LN145, and the drug is really just these TILs that have been amplified
Okay.
and taken from the tumor. So they harvest these tumors. It takes them 22 days to grow up these TILs. TILs are shipped back. You get 7 days of chemo, and then you get a bunch of infusions of this interleukin-2, which boosts the TIL population.
And these are your own.
This is just
started with your
this
own
is for
cells.
cervical cancer.
Okay.
This is for recurrent metastatic persistent cervical cancer.
Okay.
This is a clinical trial that they did recently of LN145.
Okay.
And so in this particular trial, the results they got were really, substantial. That in fact they got a 44% overall response rate, and the disease control rate was 85%. So that is really significant in recurrent, persistent, metastatic cervical cancer that has failed all other treatment options. So, it would be nice to say that this adoptive cell transfer will be used in other cancers, but so far it hasn't been that successful. Melanoma, and now we have cervical cancer. So what this tells us is that the immune system and cervical cancers are indeed a immune hot cancer, and that immune-based approaches and combinations are probably going to be the best way to approach this disease, as was with melanoma.
Good.
So there are issues with this approach, issues with this adoptive cell transfer using TILs. It requires an immunogenic tumor. That means a tumor that has these TILs inside of them, and very few tumors have that. And you have to have access to this tumor. It has to be resectable. You have to be able to remove it, and you have to be able to remove these TILs in their microenvironment. So, that alone is a bit of a hurdle.
Right. It would depend on where you live, I would imagine,
and where your tumor
your
is.
doctor. Yes,
and
I'm just
your
thinking
tumor
even
has,
if someone's going to be able to do that kind of biopsy.
and whether your tumor has these TILs, and it has to, it can't just take these and pop them onto a slide like your typical biopsy would do. It has to keep these TILs alive. So that's a whole different type of biopsy.
So there are a few barriers.
Yeah.
But it's promising, 85%.
Disease control rate, 44% overall response rate is very, very substantial.
For that advanced.
And then secondly, the patient has to be able to tolerate this lymphodepletion, and of course delays of the TIL regeneration. This lymphodepletion is, some very harsh chemotherapy drugs, cyclophosphamide and fludarabine for 7 days. It's wiping out your immune system. So it's not just standard chemotherapy. This is almost like what they would do in a stem cell transplant. The process is expensive, it's laborious, requires specialized labs. And so far, as of prior to this last study with LN145, only melanoma cells have had CD or TILs with cytotoxic activity.
Okay, so really what you're sharing this for, because it's clearly not immediately accessible to all, is you're saying, hey, if in even the worst case scenarios, there's something kind of coming around the bend that has some great promise. And I suppose for those who meet certain criteria and have the funds, this would be something you could access now.
Well, what I'm trying to get at is that this is obviously a tumor subtype that has great immunotherapy potential.
Okay.
Likely due to its cause of it being HPV related. Okay. It's going to have a lot of antigens that the immune system is going to be able to recognize. So, whenever you have a cancer subtype that is caused by a virus, it's going to look very different to the immune system than a cancer that is not, viral induced.
Got it.
Because it's going to have a lot of different proteins and antigens that the immune system could potentially pick up on.
Okay. So really, here's a good example of something that's coming down the pike and is available in clinical trial now. And what was the name of that trial, by the way, if people want to look it up?
LN 145, I believe.
LN 145. Remember, clinicaltrials.gov. Alex mentioned that earlier in the hour. You can have a look there and see if you can find that trial if it's relevant for you. But the main point is there's almost certainly some immune system.
Yeah, so what I would like to do is really emphasize the fact that we're going to see a lot of different immune-based combination approaches.
For cervical cancer.
Cervical cancer. Now, obviously, you want to make sure that you do have this immune hot subtype.
Sure.
And a large proportion of women will.
Okay.
Obviously, based on the statistics
and you
of the
said you could do that
co-amplification.
with genetic testing or with
testing.
fish testing.
Always get genetic testing, but you can also use fish testing, which is a poor man's version of genetic testing.
Okay.
Yeah, so on that note, since these cancers tend to have high PD-1 expression, cervical and vulva, vaginal, pembrolizumab, PD-1 inhibitor, was used recently. It was used in a trial of women that had recurrent metastatic disease that had, or persistent, and in other words, the treatments were not working. So what they found, and in par with what we've just discussed, is that there was a good response rate in the women that had PD-L1 positivity. So once again, this co-amplification of PD-1 hot tumors. And so in the PD-L1 subpopulation of this trial, they got no responses in women that didn't have PD-1 positive disease. In other words, the tumors were not immunogenic. But in the PD-1 positive patients, the response rate was 14.6%. Progression-free survival was 2.1 months, but the overall survival was 11 months, which is fairly substantial for late-stage cervical cancer, which can be very
treatment
aggressive.
resistant.
Yeah, treatment resistance. Yeah. Yeah. And so another interesting study came out, and this would probably speak to the immunogenicity of these tumors. Radiation therapy has known to definitely be a benefit in helping hot tumors become hotter to the immune system. In other words, more recognizable.
Okay. So
in a recent study, a form of radiation therapy called brachytherapy was looked at. This was it was kind of a what we would call a multi-approach study where they looked at a bunch of different approaches and went back and questioned the patients and said, well, you've survived this long, what have you had? And so they were looking at people that had had a combination of what we call brachytherapy, and they were referred to as a brachytherapy boost. And so what it was some women have had these microscopic brachytherapy seeds planted around their tumors. And then the tumor came back for some reason, and they went on with external beam, because typically you can have external beam maybe once or twice, but you can't keep radiating the same tumor because it's a heavy dose. With brachytherapy, it's a bunch of microscopic seeds, they use it for prostate cancer too, that are implanted directly around the tumor. So if you have brachytherapy, you can always have external beam radiation at a later date. If you have external beam radiation first, then you can't really get brachytherapy after that. There's no point. So it's what they refer to as internal radiation. And so what they found is that when women had brachytherapy or internal radiation, as well as external beam and chemotherapy, they had the highest survival rates. So this dual radiation therapy approach of internal radiation combined with external beam, which is not something you would normally, see as a treatment plan, was very effective. And more important, the highest survival rates were found in women when it was done within this 8-week time frame. So, getting that chemotherapy and external beam radiation within 8 weeks of getting the brachytherapy seemed to really really create a long-term survival rates.
That's an interesting and important point.
It is,
about
yes.
how many of these treatments we're discovering are very synergistic. They can really help each other to work better when you get them within a certain time frame. Even certain types of therapy administered within a certain period after surgery can make a really big difference.
Yes,
right?
yes,
So,
definitely. You want to have surgery within, or you want to have your adjuvant therapy as close to surgery as possible. There's a magic number for every type of cancer. You have to heal first, obviously, but the sooner the better in most cases.
But that's a kind of another good point, that you really want to make sure that your oncologist is looking at all the pieces synergistically, not thinking we'll try this treatment and then we'll try this one and then we'll try this one, but how could we use these together so that ultimately you end up really overall generally receiving less treatment with greater benefit.
Yeah, ironically, in this brachytherapy study, I don't believe they set out to look for that. They just were doing a review of a bunch of different treatments, and they noticed that these women that had brachytherapy as well as external beam radiation had the highest survival rates.
Interesting, yeah.
So it was a retrospective study in that sense.
Wow. Okay, good to know. All right, what else would you like us to know about?
Well, that's it. I think we've pretty well covered everything that I wanted to cover for this.
Okay.
I think
for gynecological cancers?
Yes.
Okay.
Yes, I think as far as cervical cancers, I think I would like to leave it with really, look into the immune-based approaches. I think we're going to see a lot more of those. And I think this is going to be designated as the new immune hot tumor subtype.
Okay, which is really exciting because there are so many new options for treating with immunotherapy.
But of course, avoidance is best. Get your HPV vaccines.
Yes,
obviously, we don't have an HPV vaccine for all of the oncolytic strains, but you can cover a lot of them.
If you're not sure if the HPV vaccine is right for you or what it's all about, Alex's YouTube channel, thecancerguy.com, has a whole playlist on HPV. That's how important you think it is for people to know about men and women.
Head and neck cancers, as many different cancers it can cause.
So if you're wondering, should I bother with that?
Definitely bother with
I'm already 50 or something.
Definitely bother with it.
Yeah, and if you just want some more backup or more of the science behind why that is, just visit thecancerguy.com and look for the HPV playlist, and you'll find more there. So what about these other cancers, uterine, vulva, vaginal, fallopian? We didn't talk about. I know we're at the end of our time, but what made you choose not to go there with those?
We have covered ovarian and fallopian and uterine and ovarian all kind of fall within the same arena.
Oh, do they? Okay.
Yes.
So the playlist on the YouTube channel probably has some good information on those as well. All right. So that's there's still two, vaginal and vulva. What made you not go there?
That was covered today.
Oh,
yes.
Really?
Yes.
I heard cervical.
Cervical is vagina. And then the vulva.
Okay. So cervical covers those ones.
Typically, yeah.
All right.
All lumped into the same category.
Okay, I didn't realize that. I had a list of 6 here, and I was wondering when we were going to look at all those. But the ovarian, fallopian, and uterine are already on thecancerguy.com. Vaginal, vulva, and cervical are kind of all one basket.
Yes.
Okay, great. So you did cover it all today.
Well, not specifically.
Okay.
But I gave some
generally.
Generally,
yeah,
yes.
That's great. It's very hopeful, very inspiring, to hear what's out there, and some of those survival rates and response rates for people with very advanced treatment-resistant cancers. That's like, if that's the worst, then we know that if we're catching things early and we're getting the right treatment, we're going to do really well with these things.
Definitely.
Yeah.
Thank you for watching Ctome TV. Subscribe below and stay informed.